This is our Leading Practices Academy on Behavioral Health and Brain Injury webinar, and we are so Infonar, and we are so glad that you guys have joined us. A little bit about what NASHIA is before we start. For those of you who may not be familiar with our organization, it's the National Association of State Head Injury Administrators. And you can see a little bit about our mission. We're a nonprofit organization that was created to assist state government in promoting partnerships and building systems to meet the needs of individuals with brain injury and their families. We're very passionate about that mission, and we fulfill that mission by providing the things that you can see in front of you. My personal passion is training and professional development. We love making connections between local and state and federal partners and all of the players in the field of brain injury. We stay focused continuously on state and national trends related to the field of brain injury. We do a lot of advocacy work in a number of arenas related to brain injury. And as always, we have a wealth of resources and information located on our website and located within our team of staff. Today, though, we're going to focus on one of the pieces of what we do related to training and education and technical assistance, and that is our Leading Practices Academies, and in particular, the Behavioral Health LPA. So we want to give you some background about why we implement LPAs, a little bit more about this one in particular, some expectations of individuals and partners who an LPA, and a questionnaire just to gauge your continued interest. And then we're going to follow up with some strategies if you have some challenges related to funding an LPA in your state, and some Q&A. This is us, your LPA Behavioral Health team. I'm Maria Crowley. I'm NASHIA's Director of Professional Development. With me are Caitlin Sinovec, who is the LPA Academy Director with NASHIA for Behavioral Health, and Haley Cushion, who a lot of you are familiar with already with the work she does with membership and member supports, and she's the Academy Manager. So just to touch a little bit more on how we started our LPA and why we do these, NASHIA likes to offer an array of level of supports related to training and education. And minimally, that might involve some informational materials, our webinars that we host. A little more involved might be some of the workshops that we conduct that are more intimate, smaller, more interactive. But we felt from hearing from some of you that it might be good to offer something that is a little more involved, a little more intensive, which is our Leading Practices Academies. They are targeted to particular populations and areas where states feel that they need support in building an infrastructure or building on their infrastructure to support individuals with brain injury in that particular field. So we started our LPAs with brain injury in criminal and juvenile justice. That is in its third iteration. And we then moved into brain injury and behavioral health. And this will be, we're wrapping up our first round of LPA graduates for behavioral health this summer, and we're going to launch the second one. And with that, I'm going to turn it over to Caitlin to share a little bit more about some of the details.
Great. Thank you, Maria. And hello to all of you who I haven't met before. So really just going to touch on, again, supporting the why of this particular LPA and why we need to focus on the integration of behavioral health and brain injury in services. So we know a lot from the data around the relationship between behavioral health and brain injury. We know that folks who have a, oops, sorry, I'm jumping ahead of myself here. First, I'm going to level set and talk about what we mean when we say behavioral health. There's a lot of different definitions out there, and really the behavioral health in the context that we're using it, this is similar to the SAMHSA's definition, is the promotion of mental health, resilience, and well-being, the treatment of mental health and substance use disorders, and supporting those who experience these conditions or are in recovery, along with their families and communities. So really kind of all of these aspects. When we say behavioral health, we mean both the person's health and well-being, but we're also talking about the services that support that. Next slide. Here's where I was jumping to, a little ahead of myself here. So the relationship between brain injury and behavioral health, we know that there's a lot of correlation between these two, right? So individuals have behavioral health conditions across the country. We know that there are certain behavioral health conditions that increase the potential risk for experiencing a brain injury, such as substance use, which continues to be on the rise across the country, both in terms of substance use as well as impacts of that and overdose. And we also know that just behavioral health is prevalent across the population. So whether or not the behavioral health condition contributed to the person having a brain injury, it is very likely that those who experience a brain injury will have had a mental health condition prior to that. We also know that brain injury can cause behavioral health conditions. At least 1/3 of individuals with a brain injury experience mental health symptoms 6 to 12 months post-injury. And we also know that there's a really increased significant risk for attempt or death by suicide for those who have had a brain injury. So there's a lot of need to make sure that our services are addressing both of these in individuals. Next slide. Yeah, so here's a little bit of the numbers just to put some data around this. So 28% of those with brain injury have suicidal thoughts and 17 attempts, comparing that with the general population of 4%. So again, looking at how significantly higher that is in individuals with brain injury. Similarly, substance use, after a brain injury, 43% have some sort of alcohol abuse, 29% some form of illicit drug use, and about almost 50% either, compared with about 7% of the general population. So then, although it's high in our general population, it is even higher in those with a brain injury. And then similarly with mental health, as we noted before, about 30% of brain injury survivors experience a mental health symptom after injury, compared with 19% of the general population. And interestingly then, families, about 85% report behavioral changes. So although it may not be a behavioral health condition as diagnosed by the DSM, there are changes in behavioral and emotional regulation that happen after brain injury that likely need some sort of treatment or care. Next slide. And so within these groups of people who are at risk, Maria, you can, I think, click forward a couple times here. We know that there are several subpopulations that are at an increased risk for sustaining a brain injury and having co-occurring behavioral health conditions. Again, this is very correlational. In some cases, it's hard to determine what came first, and they both are in existence. So folks who have lived experience of homelessness, survivors of domestic and interpersonal violence, those who have been incarcerated, those with a history of adverse childhood experiences, living in poverty, and those who are veterans, all have collectively a higher risk of having both a brain injury and a behavioral health need. What is really important to note about these populations is that they're often less likely to seek medical care for a brain injury or diagnosis. They have a lack of access to healthcare and a lack of access specifically to rehabilitation and treatment for the brain injury, as well as behavioral health services. When people aren't able to access the care that they need, this really impacts quality of life and ability to engage in systems that might be able to help them and help them live well within their communities. Next slide. And so there's, again, a relationship between TBI and behavioral health, as we noted, is correlational. Pre-existing mental health conditions can also impact how somebody recovers from a brain injury just by biological structures of the brain, social factors that might exist, and resources the person has. When there's a coexistence of symptoms, especially for someone who's sustained a brain injury, diagnosis might be inaccurate or delayed, and not treating either the brain injury or the behavioral health issue can impact recovery and overall function. Next slide. So a little bit more, again, on this relationship. Again, substance use is continues to be a growing issue, especially within the US, both as a risk factor for experiencing a brain injury, and then specifically the issue around to overdose. So the introduction of Narcan and naloxone was an incredible resource, right, to prevent death by overdose. However, now we have a lot of people in our communities who have survived an overdose, but an overdose, especially for a significant or a longer amount of time, is an anoxic brain injury, an anoxic head injury. So we have a lot of people in the community who have survived an overdose, who've been resuscitated, but have not gotten treatment for the cognitive impacts of that. And there are folks who maybe have experienced this multiple times. So it's a huge gap in care, and I think a huge opportunity for integration of behavioral health and brain injury. And again, ongoing substance use can impact somebody's ability to engage in care and overall recovery. And we also know that a brain injury can impact somebody's ability to engage in traditional substance use treatment. A lot of substance use treatment facilities use behavioral approaches that have rules, that have guidelines, that have restrictions around behavior requirements to sit in groups for long periods of time. And that can be very challenging for someone with a brain injury. So a lack of accommodation and awareness can really limit somebody's ability to engage in that type of care when they're interested and ready for recovery. Next slide. And then adding into all of that, a lot of these populations that we've already talked about, people with behavioral health conditions are also more likely to experience chronic conditions. We know that brain injury can also contribute to development and ability to manage chronic conditions. So there may be folks who are managing behavioral health conditions, a brain injury, diabetes, cardiovascular disease, right? All of these things at once that are very, very complicated and difficult to manage on your own. They impact each other, right? Unaddressed diabetes and diabetes in general shows that it decreases cognition in individuals, even in middle age. We know the same around cardiovascular risk. And so all of these things can really impede each other, especially when they're not being treated. Unfortunately, those with behavioral health conditions are more likely to experience stigma in general healthcare services and have decreased access to medical services. So maybe not only are they not getting the mental health care that they need, but they're not getting the preventative primary care or the rehabilitation care for their brain injury. And we know, I think all of us doing this work means that results in poorer outcomes. And that is the opposite of what we are trying to achieve. Next slide. So, this is a significant issue. Again, you're all here because I am assuming that you all have recognized that there is a need for behavioral health and brain injury services within your state. Some of the limitations is that there's a lack of awareness in the behavioral health system around the prevalence of brain injury, and that there's not necessarily resources and knowledge to address the needs of those with brain injury who access behavioral health services. But luckily, we know that there are solutions for that, although not easy. I'm going to make it sound like it's really short and simple here, but we know that it is more than that. Increasing education and awareness of brain injury can mean a lot for the people who are accessing services, and developing tools and resources that support these individuals when they're accessing care can be really beneficial and really result in improved outcomes. Next slide. So there's some momentum, right? A lot of you have probably at this point heard about the 988 crisis health line. There's a lot of focus now on substance use treatment, overdose prevention, and response across the country. So there's a little more interest and a little more funding, especially for behavioral health currently. And so it's a really good time to take momentum of the changes in systems. And that's speaking federally, because a lot of states have their own individual initiatives to address these issues. And so there's a lot of best practices, and this is a good time to get a seat at these tables to really influence care and make sure that they're being inclusive of both brain injury and behavioral health when they're developing out systems and services. But from the perspective of you all, it might be challenging to know the behavioral health system is huge, it's vast, it's complicated. And so it might be challenging to think about, where do we start? Who do we target within the behavioral health system? There's substance use, there's mental health, there's inpatient, there's community-based, right? There's a lot of facets of that. And then how do we engage with how do we develop these partnerships, engage these partners, and develop meaningful protocols and changes to their programming that can support individuals? And then finally, how do we evaluate that we were effective? And how do we scale up, right? How do we make sure that something that we demonstrate to be beneficial in one area gets applied across our state? And that is really what we're looking to do through this behavioral health LPA, is that we can provide the technical assistance to help your state develop a customized approach to improve those outcomes. Every state is different in terms of how resources are delivered, how they're structured. And so giving you the opportunity to learn about best practices and promising practices and apply those to your specific communities and structures. Next slide. So this is a teaser. So we use the behavioral health and brain injury systemic impact model to guide this work in the behavioral health LPA. This is based on the Administration on Community Living's behavioral health guide, considerations for best practices for children, youth, and adults with TBI. There are some very familiar names as authors in that particular document. And so we use that as a basis for developing our systemic impact model. Next slide. So this model is really a way to help frame and target what you will be doing for your LPA year, and where you need to focus with the entities that you are working with. And that's going to be very varied across states, but really focusing on training, which is doing initial training, brain injury awareness for behavioral health providers, on what brain injury is, on prevalence, on identifying that this is a particular need that needs to be addressed. The next level up is then focused on screening, right? How do we integrate screening practices into these entities so that we are identifying folks with brain injury and able to adjust our services accordingly? The next step on that would then be focusing potentially on intervention, right? So how do we support those who are working with behavioral health and brain injury to implement best and promising practices in the direct services that they're delivering, through recovery programs, through harm reduction programs, through individual therapy, through psychiatry and prescribing of medications, right? There's a lot that could be addressed here, but there are interventions that are effective for these individuals that we can support people in adapting and implementing within their program. So those first three steps are really provider and kind of program based. The last two are more of our 30,000 foot focus, right? So we can change one entity and have really good outcomes from that one entity, but then we want to spread it, right? We want this to be something that happens across our state. And that's when we need to start looking at some more systemic level issues. What are barriers to accessing services within our state or within certain organizations? What are things that we're doing well that we want to replicate across this area? Integrating statewide brain injury across behavioral health systems would be incredible, right? So that could be a goal of that systemic level. And then finally, looking at kind of even further at maybe 50,000 feet is policies, especially with state-driven services. Policies have a lot of influence around what we're able to do. I think, Rebecca, you gave us a great example of that at the very beginning of this, on how policy and advocacy impacts what services are able to be provided, what funds are allocated, who's sitting on these boards and advisory committees. And so sometimes to make those direct changes, we need to address the policy level. And that might be what a state decides to focus on for their LPA year. So next slide, and I'm going to turn it over to Haley now, who's going to talk a little bit more in depth about what this looks like when we are in the LPA.
Okay, great. Thank you. Those of you who are current Academy participants or former Academy participants, either in the Behavioral Health LPA or the Criminal and Juvenile Justice LPA, will recognize some of these components and some of the next things that I talk about. So first of all, one of the things that we wanted to go over and make sure everybody understands is what is exactly involved in the LPA. So first of all, the big key is that you get that strategic and customized TA that is basically exactly what you need for where you're at. We offer that in the form of lead only meetings every other month. And then in those other months, we have state team meetings. And then we bring in an array of subject matter experts to meet quarterly and at the beginning and the end of the LPA. Also, we have a lot of online resources in our hub. We also have, of course, peer-to-peer contact and networking, and then we have some sessions sprinkled in throughout the year where you get to talk to other Academy participants and talk about some of their wins and some of their challenges, and kind of go through the process with them to figure out what might, what strategies might work best in your state. Also, we have, like I said, a kickoff meeting at the very beginning that really covers more details about the LPA. This is a great meeting to bring all your partners together to really get their buy-in and talk about exactly what to expect for the 12 months. And then at the very end, we have a summit that really goes over detailed work of what each state did, and of course have another subject matter expert there as well. Tuition is $10,000. If you need flexible billing, that is a conversation we can certainly have. What we like to say is that it's best to go in partnership with other partners for the tuition. That way that they have a skin in the game, so to speak. They have some buy-in there as to really get in to the process, and especially because they're helping you cover the cost of it. Next. So a little bit more about what you get from NASHIA for the tuition for the LPA is you have, we're going to meet with lead staff, the primary contact. That could be 1 to sometimes 3 to 4 to 5 people. And we're going to make sure that you're comfortable with your work plan, you're comfortable with where your state is going for the 12 months, to make sure that everything is in line with your expectations there. We will not recruit partners for you because that is where it's best for you to form that relationship with those partners, but we will certainly help with suggestions or things to provide them, or ways to maybe reframe some information to help get their buy-in. We also assist with plan development, and this is the plan that is developed within the first several months of the LPA. For those returning Academy participants, you will start right back into where you left off and not skip a beat with working through your work plan that you've already created. You will also, we will engage with the staff routinely, your staff routinely, to make sure that everybody is in line and in communication on what is going on. Work plans will be reviewed very regularly to make sure there's no need to adjust or modify what you're working towards. We do all the recruitment and the engagement with the SMEs for the LPA. We lead and coordinate all the LPA activities, and of course provide those online resources. Next. So this is what Academy participants' roles and expectations are, is that you do make sure that you have a lead staffer or a primary contact. If you are with an organization that is not your state brain injury lead agency, we just do ask that your state lead agency be kept informed or involved in some way as you go through the LPA, just because they're a great partner to have, and that is one of the missions of NASHIA, is to make sure that we got that good relationship with states. One of your expectations would be to recruit those partners and to help bring them to the table with the LPA year, engage in plan development, engage with the LPA staff, and of course, work on that work plan. That work plan is going to be made with you and for you, and you're going to be the one that will be the hands and feet of that work plan once it's ready to be put into motion. We would love to have the participation of all partners and lead staff in all LPA activities, just because the more you're involved, the more you're involved. So we would just expect for everybody to participate in all activities that their schedule can certainly allow. We want you to access that hub and those online resources. They are curated with the LPA in mind and your work that you're doing in your states around behavioral health. And of course, disseminate information about LPA activities. This is, of course, to help work on that systemic change. Also to get the word out of the awesome work that is done over the 12 months. And of course, to just really affect change in your state. Next. Okay, Caitlin, I'm going to let you take it from here.
There we go. So this is just a brief example of what the 5 states that were involved in our behavioral health LPA year 1. So this might look very familiar to a couple of you on this call today. So just kind of an overview of what this can look like. A lot of our states for this first year, we're really working on that partnership development, the training and the screening piece. So it's kind of first levels of the systemic impact model that we use. But then one state also was really focused on making systemic change by developing a roadmap to address gaps and barriers for individuals with brain injury and behavioral health and accessing services across their state. What was keeping folks from getting behavioral health care when they have a brain injury, and what was keeping folks with behavioral health needs from getting brain injury services, and really identifying a way for the state to move forward in removing and minimizing those barriers. Other examples include increasing behavioral health networks for brain injury survivors by offering training and piloting brain injury screening. Other examples, developing a training and screening protocol that can be implemented with behavioral health entities across the state. That started through a needs assessment and identifying behavioral health partners. So sometimes, you know, a lot of the groundwork is focused on building these relationships between these two. So I won't read them all out loud to you, but this is just some examples of what folks have worked on over the last year and are really seeing some really great movement from the work that they've done. Next slide. I'll turn it over to Maria.
Who will take herself off mute. Thank you. So maybe you are thinking this is all well and good. How am I going to fund this venture? And we want to sort of close out what we talk with you about in terms of some strategies that might help you think through how to do that. You don't have to do it by yourself. There may be some things on this list that you hadn't thought about before that could help you think through how to fund something like this, and that also are good ways to get some buy-in from the partners, the very partners that you're wanting to bring to the table for this initiative. So perhaps you have a current TBI grant or other grant with your state or with your program that's tied to behavioral health. Certainly, if there is some connection with your current activities, with your ACL TBI grant, this would be something that you could fund with that money. Maybe consider some approaches related to blended funding. Are there other partners you can bring to the table with you to share the cost? It may be that you have been spending some time with your state mental health system, and the two of you could talk about blending funding with each other in order to arrive at the same goal. Maybe you have some other community health providers that you might want to partner with that are interested in this particular arena. I just added this one in as it occurred to me in looking through some of our slides. You can partner with your University Centers for Excellence in Developmental Disability, one of our LPA Programs has done that very thing. In fact, they've kind of taken the lead with the initiative with LPA and behavioral health. Maybe you have a protection and advocacy program in your state that is focused with either monitoring or mediating or guiding a program towards better practices and supports for people with brain injury. They may very well be interested in partnering with you in this venture. Maybe your Veterans Affairs program is currently focused on treatment courts, problem solving, or specialty courts. They might be a good partner for you to consider. Or there may be one of your state affiliates, your Brain Injury Association or your Brain Injury Alliance, that is wanting to work with you in this space. Maybe they can help locate some funding avenues that you hadn't thought about. And most assuredly, I don't think I'm speaking out of turn for anybody that is an affiliate. They do a lot of advocating in the community that you as a state agency may not be able to do. So they might be a good partner to bring to the table with you. There may also be some new funding sources that you could apply for that would lead you to the same place. Grants related to opioids and overdose within your state or your city or county. SAMHSA offers grants on a multitude of things. There may be some funding that you could access there, or, last but certainly not least, some private foundations in your community that you could tap. So there are a lot of different ways to approach funding, and I hope this has given you some food for thought in terms of what you might be able to do. Haley, turning it back to you.
Great. One of your questions may be, what do we do now? We are interested. One thing we would like for you to do, if maybe you are all in or kind of in, unsure, on the fence, we would like for you to complete this interest questionnaire, and I'm putting a link in the chat as well. And I'll be sending this to you in an email after the event today with the slide deck and other information. But we would love for you to complete a interest questionnaire to let us know a little bit more about a project that you would love to put together. I think I've got a little bit more on the next slide. It'll include the primary contact, what you're hoping to achieve, a description of the population you wish to reach, a list of partners or potential partners, and funding source. If you don't know the answer to all of these, that's certainly fine. We can also help with some of the answers to some of these as well. But we would love to have more information from you if you do have some interest. Once we have your information and we look at all of the states that have applied, we will determine the set number of states that we can take for the academy for the upcoming 12 months. We will be in touch with everybody with a acceptance letter. Let's see. And real quick, one of the slides that I think is in another version of the slide deck was information about our timeline of when the LPA started. It does begin in August, so you can expect to have your first meeting mid to late August for the kickoff, and then it'll end up in July of 2024, with that summit being mid to late July as well.
Haley, are those dates on the LPA NASHIA site?
The beginning date, beginning month, is on the LPA NASHIA site. Yes. Awesome. All right. And this is the site. I also added it in the chat as well. So you can have a quick reference to that site. There's a lot of information there. There's a one-pager if you would like to present a one-pager to a potential partner or potential funder. or whoever might need to see that one pager. There's one there as well. The link to the questionnaire is there as well, along with our lovely faces and some more information about the LPA. You can also look around at the Criminal and Juvenile Justice LPA, and they have highlights from their first and I believe maybe their second year of work. So you can kind of see what other states have done, even in a different topic area, and what they have accomplished over their 12-month time working within the LPA. All right, next, I think we're ready for questions. We will have some time, of course, here to take some live Q&A, but if you are on your drive to the supermarket later today and you think of a question you would like to ask, please feel free to send it my way. And then if it's more of a question for Caitlin or Maria or Becky, our executive director, I will kind of farm those questions out to make sure they're going to the right person. So please let us know if you do have any additional questions. All right. So like I said, everybody who registered today will get an email with some follow-up information, including the slide deck and some links. We want to make sure that you have all the information to make an informed decision about if this is a good fit for you. But we are definitely open to some questions.
Yeah, go ahead, Nikita.
Hello there. I do have a question regarding the funding. So are you talking about for example, I do work with the TBI team here with Western Tidewater. Are you saying that the agency that I work for in the BIAV could help fund me to participate in the LPA?
I would say that it is possible if they have some funds they can set aside to do that. And that's a conversation you guys could and maybe should have.
Okay, so that is what the funding, that slide meant, is to find. Okay, thank you for that.
Sure.
And it would be, you know, it would be your whole organization would take on the LPA. It's not really
Just an
meant for,
individual.
Right.
yeah, it's not really meant for an individual to have to tackle the whole 12 months on their own. It really is meant to be, you know, an organizational project, especially
Okay.
since you are looking at systemic change within the state structure.
Do you mind if one moment, I'm going to close my door.
No,
Sure, go ahead.
In fact, Amanda, if I know I hate to call you out, would you just mention the partners that you guys have at the table?
Yeah, sure. So I'm Amanda. I'm in Massachusetts, and I've been doing the first year of the LPA. And so our partners include, I work for the state lead agency, Massachusetts Rehabilitation Commission, but also at the table we have our BIA, in addition to our Department of Public Health, the Bureau of Substance Addiction Services, our Department of Mental Health, and Mass Health, which is the insurance agency for Massachusetts. And I feel like I might be forgetting somebody. I think that's it. There's 5 of us. So myself, oh, that's why, because it's myself and another representative from MRC. That's our SHIP director, our statewide head injury program director is there as well.
Awesome. Thank you. Steve, did you have a question?
Yes, it's not $10,000 per person. It's $10,000 per team. Maybe is that the way to describe it? Okay.
Yeah.
Thank you.
Sure.
Just a quick question. This is Jim in Iowa. You may have already mentioned this, Haley or Caitlin, but when did you want the interest form back? Do you have a deadline for that?
Yes, if you are a state who is currently involved in LPA year 1, your deadline is June 30th. If you are a state who is not engaged in our LPA year one in new state, then is it July 15th?
Okay,
7th. Thank you, Haley. July 7th for those who are not in the current LPA year.
okay, thank you.
You will have access to this recording. Haley can send that to you. And I know this is something Caitlin mentioned, but we do meet you where you are. So if you are at the beginning of trying to formulate a partnership to impact your system, great. If you have some inroads already and you're looking at adding some elements to that, great. You know, if you have a pretty solid relationship, you've done some training, maybe you just want to focus on, you know, more systemic things or changing some policy, that's great too. You know, any of that or all of that, you know, makes this something that's applicable to you because we customize it for your team.
Excuse me, I have one more question. Thanks, sorry. So is there like a cap on how many people can participate with within that one agency?
There is no official cap for how many people can participate per agency or per academy participant. We would only say keep your team manageable. So it could be that your project for the 12-month warrants a 20-person team and they all have a job. And it would be one of the roles of the lead staff or the primary contact to help manage that 20-person team and make sure everybody's got a job and doing, you know, fulfilling their role. We have some current LPA participants that have a 5-person team and they are good with their 5-person team, and that's what their project warrants. So it really depends on your goals, the partners, and what you feel would be appropriate for you all.
Okay. And I'm so sorry. I'm so
You're
interested.
good. This
Okay.
is your time to ask those questions.
Okay, I don't want to take up anybody else's time. So what is it safe to say that this is more geared towards the management and the department administrator, the clinical administrators, the program directors over the brain injury or mental health department within the agency?
I think it can be a mix of both. Again, kind of speaking to what Haley said about depending on the project, you definitely want some decision makers at the table, people who can make decisions or meet with people who can make decisions, right, to move things along and make sure that things that are developed can actually be implemented. That being said, we do have some states that have direct providers as part of their partner group because they're helpful in informing, talking about what's realistic. They're sort of a liaison between the agencies. So it definitely can be a mix of both. And the people who attend the different meetings can change and fluctuate a little bit. So you might start out with a certain set of partners, and then as you add additional people on, they may then start joining certain meetings, or there may be topics of our all-state meetings where everybody comes together that are more relevant to some partners than others. So there's a little bit of flexibility in that, as long as the lead people stay consistent throughout. There may be some people that get added in depending on sort of what progresses and develops and needing that additional voice at the table. So.
Okay, thank you so much.
Does anybody have any maybe not questions, but any reservations or maybe a hurdle that you feel like you would have in order to participate?
To me, I would say the biggest hurdle, and as an ACL grantee, is managing the work groups we participate in through the grant, plus this, plus, so like, I feel like my special projects, if that makes sense, and the different groups that I'm a part of just keep growing. And they have overlap in weird ways, but not enough overlap for them to be combined. Does that make sense?
Absolutely.
To where I'm kind of like, okay, and part of the problem with this, and I actually had this problem because we did the first year of the criminal and juvenile justice, and then we opted not to do the second year. And now that our criminal and juvenile justice one, actually about halfway through, shifted and became more of a behavioral health one. So that's why we're looking at morphing even the group that was doing, it would be the same work group. It's just really the topical interest became more behavioral health. But I find it hard since I'm a part of the world. I understand, like, this is an ACL work group, this is a NASHIA thing, this is da-da-da, but I find it really hard explaining to my state partners all of these different entities and how they are interconnected and are kind of like a Venn diagram. Does that make sense?
Yeah.
And so that's one of the barriers that I'm having in thinking about what taking on something more, how would it fit in with what's existing on my partners' plates, and how to really make sure that all of those efforts are kind of have a synergy to them and going the same direction.
Absolutely. That's great to know. And thanks for sharing that. I will say, and I'm going to speak for Amanda a little bit. Amanda's group in Massachusetts were already kind of organically together, doing some work towards the grant. And then it turned into a LPA focused work as well. Amanda, if you want to add some of that, and I don't know, Jim, if maybe you have a little bit that you could add too about, that would kind of address what Rebecca was talking about. But I know you do have experience with the LPA, but I was just wondering if some of our current participants have a little bit more to add there.
Yeah, because Tori's kind of taking the lead there, right? Jim?
Pardon me?
Tori's kind of taking the lead there, right?
Yeah, in our current one, our behavioral health, we're working with our USAD at the University of Iowa, the black and gold Iowa Hawkeyes there. And really they've done a great job taking leadership. And the nice thing about their involvement is that they're enmeshed in a good way. That often has a negative connotation, but in a good way with our state level systems in behavioral health, with our HHS partners. And I think, in fact, we just had our first session with Maria this morning that was attended by over 200 folks, I think. And so we're really excited about, the possibility of being able to, gain some traction for that. And we did also participate in the first Leading Practice Academy, and our focus was on, we kind of thought of criminal and juvenile justice, from the court system and child welfare. And so we were, and maybe to speak to your issue, Rebecca, I mean, during the LPA, we were really able to put together a group of people that we were able to, morph, if you will, and add some new partners and build that into our current work in our ACL grant. And, now have about 5 states who have interest, you know, in this intersection of child welfare and brain injury, and really excited about the potential not only in Iowa to kind of move across state level systems. So I think what it does is it really allows you to take the partners you have in your different, you know, areas of focus and you know, bring those champions aboard and create some synergy that you might not have otherwise, and bring some people together that, you know, maybe don't collaborate or haven't collaborated in the past, and allow them to collaborate. So it's a great opportunity.
Thank you.
I can share a little bit of what we've been doing. So Rebecca, I had set up a really a leadership team meeting for the grant. And so that's where BSAS and DMH were already at the table because they're grant partners with me. BIA is there as well. And so it felt very natural that this creating a roadmap was one of our goals, but not till like year 4 of the grant. And so I had said, this is an opportunity for us to work on our grant goal earlier on in the process. And so everybody was very happy to sign on and do that. I will say that the NASHIA team was absolutely fabulous in that they joined our existing meetings. So they join every other month since we meet monthly. So 1 month we focus on LPA and 1 month I give grant updates, so that I wasn't trying to coordinate too many people to add another meeting on their schedule. So it just felt very natural to bring that leadership into the LPA. So that's kind of how I utilize it.
I like that you kind of describing how to do that, because I think that would be a good way for me to do that as well, you know, of integrating it into already kind of some existing update stuff.
Cool. Thank you.
The difference between, let's say, Jim's example in Iowa and Amanda's example in Massachusetts kind of shows the flexibility that that the LPA can provide to kind of mold to what you want to do in your state and what your state structure is, and or your organization structure and how your organization works with the state or your affiliate. And you know, it really does have that level of flexibility to include everything that you want to. Like you were saying, Rebecca, you know, you did have a criminal and juvenile justice focus, and it kind of shifted towards behavioral health midstream. So there is, you know, there is some flexibility to, you know, to make those adjustments or those modifications along the way as needed, because we are tailoring the TA and the resources and everything to each individual state, even though we have multiple states working towards an overall main goal. Every state is different.
Great, thank you.
Thank you. We appreciate y'all joining, and you can, you know, if you think of other questions, you can always shoot us an email and we're happy to address those. But we appreciate you and hope you'll sign on with us. And thanks. Have a good rest of your day.
Thank you.
Absolutely. Thanks, everyone.
Take care.